Hello and good evening, everyone. Welcome to the 109th Blue Health Virtual Seminar. Blue Health Virtual Seminars is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this session is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leaders in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Ethiopia. And today it's our pleasure to
कॉल
have Dr.
डिस्कनेक्ट हो गया।
Narendra back here with us. Previously, Dr. Narendra have given a session on the topic of innovative practices in orthopedics. And now he is back again to give us a short session on the robotics in joint replacement, benefits, and patients' outcome. To give you a background about Dr. Narendra, Dr.
स्क्रीन पे ये
Narendra
नहीं हो
is
रहा है मेरा
the
ऑपरेशन।
chairman of Leukemia Group of
शेयर
hospitals
अभी
and
बोला ना
chief
इधर
joint
रुको स्टार्ट
replacement
होने तक।
surgeon. Dr. Narendra is a
या बट
renowned orthopedic
कॉल
and
शेयर
joint man, orthopedic and joint replacement surgeon and the visionary behind Pune's largest network of advanced orthopedic specialty clinic,
स्क्रीन हालत नहीं
Leukemia
है तो
Hospital, which strives to make
तुला
a
म्हणलं
high,
इथं थांब म्हणून इथं।
affordable orthopedic care accessible to all. And Dr. Narendra has received specialized training at esteemed institutions globally, achieving advanced expertise in robotic assistant knee replacement and minimal invasive spine surgeries, and an influential consultant on international platforms. He has been panelist in the regional forum of SAA.
गुड इवनिंग कैन आई स्टार्ट द प्रेजेंटेशन नाउ?
Yeah, please go on, Doc.
Yes, so good evening from Pune, India. I'm Dr. Narendra Vaidya, and this is the second CME for organized by Blue Health. So first of all, let me express my gratitude to Blue Health Ethiopia and all the attendees here. And I'll be sharing my experiences in robotics. Incidentally, I'm the first surgeon who brought robotic surgery in knee replacement and hip replacement in India and entire Asia, where outside US, it was the first automated robotic surgery which we started. So Lokmanya has got multiple orthopedic centers in India. I am chairman of Lokmanya Hospitals Private Limited, and am practicing in this field of orthopedics and arthroplasty for last 32 years, and having experience of more than 50,000 joint replacements and 15,000 plus robotic knee replacements and hip replacements. So robotics has really brought a lot of sort of it's a development which has brought a lot of reliability in the case of arthroplasties. So today let's go through that. Okay, so yeah. So knee replacement is one of the most successful surgeries of last decade. Incidentally, the WHO had declared the last decade as a bone and joint decade, and they ranked the total knee replacement as one of the most successful surgery of last decade. Now, knee replacement or knee arthroplasty is not pertaining only to total knee replacement, but it has got patellofemoral replacement, partial replacement. Then we have got a total knee replacement and dual compartment replacements, which we are very regularly doing in our centers at Lokmanya Hospital in Pune, India. Um, yeah. Can I start now? So even if after the the knee replacement surgery is a good surgery, still 20% odd patients are not very satisfied because the recovery is slightly lengthy, activity is limited, and expectations of the patients are not met. There are some patients with anterior knee pain and knee doesn't feel normal. चाललंय का विचार त्याला जाऊन बाहेर. So we have to find a solution because every one patient after five patients is not satisfied. So continuous research has been done where three T's. I always tell that there are three T's of advancement in joint replacement. First is the tools. That means the modern implants, the designs, materials. techniques like minimally invasive surgery, cruciate retaining, express TKR, uni, etc., and technology that is navigation, ortholine, and robotics. So today we are going to cover the robotics. There are two variables to improve the outcome. One is the implant design, and second is accuracy of implantation. Implant design hardly have impacted the patient satisfaction. So the most important determinant of a happy patient is accuracy of implantation. The implantation in conventional knee replacement depends on many factors. There are a lot of variables like the femoral head center, center of the knee, center of ankle, physiological interpersonal variations also as there. So there are too much variables when and it depends on the surgeon's perception. So one surgeon can differ from other, and then it can give variable results. You can very well see that we get patients who are obese like this, patients who are high thigh girth, less preoperative range of movement, and so these very severely affect the outcomes. Soft tissue releases balancing is very subjective in conventional knee replacement, and that's why the results are variable. And if you don't have accuracy of implantation, then what is looming is the disaster. You can see many X-rays which I've got from various centers across the globe where the implant was not implanted in an accurate position, and which has led to disaster. So we have to take help of science. There is no doubt about it. And continuously now in all fields of life, we are using technology. I always tell my patients now, if we had to go to some other place, we were going by asking address to the people, and that used to take time, and we may not have reached to the absolutely correct spot. Now we take help of GPS, and which guides us to the correct spot. It tells us about the traffic conditions. It tells us about the difficulties, and we can plan the things absolutely perfectly. The same things are used in navigation and in robotic surgery, where we have got technology which helps us. So what a robot offers is alignment in all three planes. It gives kinematic alignment because everybody's knee is different. So we have different axes of alignment, and it objectively analyzes the ligaments and helps in ligament balancing. So what is a robot? A robot is a machine, especially one programmable by a computer capable of carrying out complex series of tasks automatically. The applications are in all sorts of knee arthroplasty, which I showed. If you take the US market of knee replacement and robotics, then you see exponential rise since 2018, and we now have global applications of robotic knee surgery. So there are various types of robots. All major companies have launched robots. Incidentally, I am the only surgeon, and we are the only hospital, that is Lokmanya Hospital, which has got all the robotic technology from generation 1 to generation 4, and we have got the most modern technologies. Robots executes the task better. It has got more reproducibility and human. So the same task, if asked to do again, a human can err, but the robot can do the task perfectly well every time it is asked to perform that particular task. But one thing is one thing you have to remember, that robot cannot replace human being. Robot doesn't have brain. You do have. So use your brain when you are using the robot, and according to your judgment, because the robot will not give you judgment. The judgment is by the surgeon. The execution and implementation of the plan is by the robot. So how robot works? The first stage is the preoperative templating. It creates a patient-specific plan. So we can have CT-based or non-CT-based, that is imageless technologies, which can be there. Robots can be classified into active, passive, semi-active, or haptic or non-haptic. Active means that once it is fed with the data, then it will act on its own, and then it will execute the plan. Passive means you have to, again, the surgeon has to come into role and then execute it. The most popular robots today are all semi-active, where planning and implementation, the help is taken from the surgeon. And these are the most popular robots across the globe. And surgeon in these type of semi-active robots, the surgeon is always in control, and it can be haptic or non-haptic. Haptics can be of various types. Haptic can be a sensory haptic, that is, haptic is a feedback given by this. and the robot will work within the limits which are given to the robot by the surgeon. So it will not exceed those limits, and it will always work within the limits of those haptic boundaries. Non-haptic robots are not popular, and we don't use it anymore. So active systems are like QS, where a robot will do all the task. The present day robots are all semi-automatic haptic or semi-haptic, planar haptic. So this is the first generation Makoplasty, which was introduced some 2 decades back. This is a CT-based 3D templating machine where you have to do a 3D CT scan of the patient starting from the hip to knee and again ankle. It gives the access, it gives the accurate dimensions of the bone, and then surgeon can plan the implant positioning according to the bone shape, size, and the morphology. So this is a video of haptic saw. The haptic saw, the initially first stage, you have to mark on the bone and specific points which are actually marked on the bone model, which the surgeon can see. And then once that bone model is actually seen on the screen, the haptic saw will come in the play, and it will work within those green boundaries only. So it is very safe. It will not damage the vessels or neurovascular structures. It will not damage the ligaments because the saw, bone saw, is working within the limits. So it is extremely safe. Second generation robots were burr-based robots, because any precision industry, if you see, apart from surgeries, then all the tools are burr-based, or they are not saw-based, and so the burr-based robots were introduced. I have been using this burr-based robot since 2016, and we have done really thousands of cases using this, where the accuracy of a handheld robotic instrument, which is image-free, is absolutely fantastic. And the best part is that surgeon is always in control. Sometimes I have seen in automated robots that robots can get stalled because ultimately it's a machine and then surgeon has to take over. In those situations, in a fully automated robot, things can really turn to be difficult, to get difficult. But in these robotic assisted semi-active, semi-haptic systems, the surgeon is always in control, and it can actually salvage any joint at that portion. So this is now mapping, which is the first stage in this burr-based robot. This is a Navio or Cori system from Smith and Nephew, where the surgeon has to move the probe on the bone, and then it creates a virtual three-dimensional image of the bone on the screen of the surgeon. You can rotate the image from all three directions, and then ultimately you get the perfect bone model. So here you can see we are marking the axis. Now we are painting the tibial upper end of the surface, which has to be replaced. And once that is done, this first stage of surgery is over. That is called as mapping. So it will create a 3D virtual image. Then you get this screen, which is a planning screen, where you can see before actually cutting the bone, you can see how the implant is going to get placed on the bone. You can see the ligament tensions. So orange is the medial side of the knee, blue is the lateral side, and then you can see how the knee is going to behave in the entire range of motion, so that you can adjust the implants accordingly, so that you get absolutely equal gaps and perfectly balanced knee when you are executing the plan. So in simple words, we are actually doing the surgery on the computer and then actually cutting the bone. So we know what exactly is going to be the outcome, and that's why the robotic knee replacement is very, very safe, and it gives predictable good results. And then last stage is execution, where we start burying the bone and we don't cut the bone. And this is like a dentist who gives shape to the tooth, and then you put a cap of the decayed tooth. Now here you can see three colors. This is the virtual image with color coded image, where red is the 3 millimeters, blue is 2 millimeters, green is 1 millimeter, and white is where actually we want to go. So this is a surface which is completely created after burying the bone, and you don't have to cut the bone. So the bone loss in this type of robotic systems is absolutely zero. And so you just do the resurfacing. Even if you call a knee replacement, it is like resurfacing of the bone. Another robot which I'm using is from Zimmer, and this is a Rosa robot, where the robot will guide the surgeon in placement of the jig. So this is a X-ray based, or it can be used as imageless technique also. There is no intramedullary intervention required, and one intelligent robotic arm is placing the instrument accordingly. And then you get this screens which will give you various values, how are the gaps, how is actually the range of motion, where how what are the deformities, and so whatever a surgeon wants to know, he gets a very objective data rather than just a perception of feeling. And this is most important, so that it is absolutely perfectly placed. So you can see the ROSA robotic arm in action. The robotic arm comes and sits on the bone, and then surgeon just has to execute the plan of cutting the bone. So you can see the this thing, final step, the surgeon guides it on the bone, and it will get fixed to the bone, and then we use the saw to remove the bone. So this ROSA system is a saw-based system, and you cut the surface of the bone. So a robot allows us to implant perfectly sized, kinematically balanced, and to a stable joint throughout the range of motion. It can be used in uni, or it can use alternative philosophies like kinematic alignment. It can be used in extraarticular or juxtaarticular deformities, recurvatum, complex cases everywhere. So, like in this picture, all the bicycles here have different biomechanics. Similarly, our knees have been also divided into 9 phenotypes, starting from type 1 to type 9. And because everybody's knee has got different structure, and this classification is slightly complex, but you can actually mimic this alignment in the in any patient by looking at the preoperative long leg X-rays. So we can have mechanical alignment, anatomical alignment, kinematic alignment, but the most important is functional alignment. This is a novel philosophy to balance the total knee replacement with minimal soft tissue releases. We don't require a CPAC classification. It allows the personalized planning as per the deformity, allows three-dimensional adjustments, and femoral or tibial cuts are taken. Some of the cases which I am going to show, you can see osteoarthritis of the knee. Here we register, and this pictures are from Velis, which is a Johnson and Johnson robot, where we determine the hip center, ankle center, the knee axis of rotate, the tibial rotation, femoral rotation, etc. Then we map the surface, the condyles, then the anterior cortex, posterior cortex, and then you get all this data, how the knee is behaving, so that you can have a perfectly balanced knee after realigning the prosthesis. So here you can see the gaps are equal, which is sub-millimeter. On the right hand side of the picture, you can see 10.5, 10, 10.5, 10.5. So this knee is completely balanced on all four directions, all four dimensions, and entire range of the motion. So this is what is actually possible when you are using technology of robotics. The knee is perfectly balanced, and knee gets complete range of motion. Here you can see up to 130 degrees motion is possible in this particular knee. So this is a demo of the Velis robot, where this is a semi-haptic, planar haptic saw, which surgeon I am holding, and then cutting the bone to the precision. And you really don't have to put any intramedullary rod, stems, or anything like that. While the required bone surface is cut, again you can check on that. Then you apply this tensioner, and then take the knee through range of motion. So you can actually see how the knee is behaving. And here you can see 9.5, 12.5, 11 gaps, which are differential, so because of the deformity, and then we are going to balance it. So I'm moving the prosthesis in slight varus, and I'm going to reduce the extension gap by taking the implant slightly distally, so I get absolutely perfect gaps. The natural knee, human knee, is slightly lax on the lateral side, so I have kept 1 millimeter laxity, but within sub-millimeter you can get complete balancing of the knee. Once this is done, then what job remains is just a mechanical job, where a surgeon will take the cutting tool, that is saw in this particular robot, and then you remove the diseased cartilage. And this is what is the final balancing, which is again showing you the sub-millimeter balancing in this case. And similarly, you now cut the femoral side. The cartilage, bone cartilage, is shaved off from the femoral bone. You don't have to put any intramedullary rod, which will take care of, which will remove the risk of something like a fat embolism syndrome, which is a dreaded complication of replacement surgery. But in this, the chances are reduced to almost none. And then you cut all the four chamfers, and then after these are done, we are ready for the implantation. So what robot allows us to give the patient a personalized alignment? Incidentally, we have started a personalized alignment society in India in knee replacement, which will allow the implants to be placed as per the patient's need and give the patient a absolutely balanced knee in every case. And this is the post-operative X-ray, which is showing perfect alignment. So these are also useful in some very tricky situations where conventional knee replacement is not possible. This is a extension malunited fracture of supracondylar portion of the femur where you can't put an intramedullary rod, and so conventional surgery is out of question, and where robotics have done wonders, and you can actually do the surgery like what I showed. It's just a resurfacing. You don't have to cut the bone, don't have to do the osteotomies, and this was a deformity pre-operatively. You can see a very grotesque varus deformity, which is from the intra-articular portion as well as juxta-articular portion. The first step was to register, to map the knee joint. So we did a mapping. We determined the center of the hip, center of the knee, then the rotations of the femur. So all mapping was done. Then implant planning was done, where you can see because of the deformity, implant planning is slightly tricky in this situation. And then implant, once it is planned, you check the cuts, and finally you are ready for budding, and proper following which you get a perfectly balanced knee. You can see completely balanced knee, and gives a very satisfactory result in periarticular, juxta-articular deformities with full correction. So you can see the graphs here. Preoperatively, the orange line is below the center line. That means it was having contractures on the medial side, which without cutting the ligament, we have been able to achieve perfect balancing with repositioning using a Cori robot. You can see a perfect alignment here. The deformities have been removed, and this is the surface of the bone after robotic preparation. And finally, you get a perfect alignment without osteotomizing the malunited fracture, and you get a perfectly good long knee alignment. And you can see here that we had a 23 degrees of varus here. This is a malunited tibia where we use robotic technique, and you can see that we got a perfect balancing. Another case where it's a very bad valgus deformity. In these situations, you required in conventional surgery lateral epicondylar osteotomy, which delayed the mobilization of the patient. But in robotic surgery, without even osteotomizing, you get a perfect correction of the deformity and long leg alignment. Another interesting case, which has a malunited femoral shaft fracture with a long plate in situ. With conventional, you require two prior surgeries of implant removal when osteotomizing the malunited fracture, and then third stage you had to do a replacement. But now with robotics, without removing the bone, and you can correct the deformities in the knee joint. You don't have to correct in the femur, and so you can see here we did a robotic surgery here, and we got a perfect alignment in spite, after even keeping the implants in situ. So the complete deformity was corrected. Another case which was operated elsewhere with a bad femoral deformity, and you can see we call it a windswept deformity. It is like valgus on the left side and varus deformity on the right side, and both were corrected using a robotic surgery. You don't have to release a lot of ligaments, and this is the final leg alignment. Another interesting case with a tibia fracture there, and here we did not remove the nail and just did a partial knee replacement here. You can see a perfect alignment, correction of the deformity, and patient is actually able to do all the activities. And every time it is reproducible, thousands of cases you will get absolutely perfect results, no variation. You don't lose the sleep over the post-operative x-rays, and it's really a good thing. The literature also is ample now. Robotics is the way, and we have published a lot of papers also in international journals. So here we can see that the results are good, and even in risky cases like post CABG cardiac surgery also, we have been able to use the robot with minimal complications, cardiovascular complications. Another paper we presented was to restore the joint line, because joint line restoration is most important goal in robotic in any knee replacement, and here we are able to absolutely do it. Other also one more paper we published was about in arthroplasty journal. So we have got a lot of international publications under our belt. One more paper of long-term study of robotic assisted UK where we got excellent results, which was published. So robotics here is to stay and is the way forward. It is the best option to tackle extra-articular deformities, allows proper, appropriate, correct assessment and correction of the deformities without cutting the soft tissues. So it really reduces the outliers from 28% of conventional surgeries to below 1%, and that takes care of all the 19 to 25% patients which were not happy with the old or conventional technique of knee replacement. Let's see some patients. A rheumatoid arthritis patient with the stiff knee and waddling gait. This patient, bilateral robotic knee replacement was done, and post-operatively the patient, you can see, is able to walk absolutely normally, and you can see the gait has improved drastically. And due to accuracy of implantation, the life of the implant also goes up from 10 to 15 years to, and the patient can expect 25 years of prosthetic life. Another case, this is again, you can see just 2 months after that, patient is able to go on the steps absolutely comfortably, and she is without any walking aid, that is stick or anything, able to climb there. Another case with a bad varus knee, bilateral knee replacement was done using Wellis robot from Johnson and Johnson, and patient's deformities were completely corrected, and patient is able to walk just about 15 days post-operatively. You can see patient is able to walk without any pain, and the gait or the walking pattern is absolutely smooth. Patient is able to go on the steps also, and without any walking aid, he is able to do all the activities by end of 1 month. He is able to drive two-wheelers also, able to ride his scooter, which he was not able to do for some years before surgery, and now he is able to do all the activities without any problem. Another bad varus case, you can see the bowing of the legs. The deformity is almost 30 degrees, and we did a bilateral robotic assisted knee replacement in this particular patient, and the deformity was completely corrected. And just 1 month after that, his legs are straight, and patient is able to walk without any walking aid, without any walking support. So this is a great advantage. One more case, which is having a complex knee deformities. Patient is unable to walk without a walker, and her day-to-day activities, the ADL activities of daily living, are seriously hampered. And so we did a bilateral knee replacement in this patient, and her walker was absolutely not required for post-operatively. And just 1 month after the surgery, patient at home can do all the activities of daily living. Another case with a valgus deformity now. All the other deformities were varus. Now here you can see the right knee is very stiff, and patient is walking with a lot of limp, and her gait is completely disturbed. So bilateral surgery was done, and just 1 month after that, she can do all her gym also. You can see the patient is doing cycling, and she's back to her happy normal life. So we have given the knee which was about 25 years younger than her physiological age. Another patient with bad deformity, unable to walk without a walker. You can see she is having a severe limp. She is barely able to move, and again, a bilateral robotic assisted arthroplasty of knee was done, and the deformity was fully corrected, and the patient is able to walk without any walking aid. And you can see she's walking in the garden without any walking aid, and able to do all her activities normally. And this patient can also do some dance post-operatively. So the joy of motion is back to her in her life, and she is absolutely perfectly fine. This patient has got a very bad unstable left knee. You can see it's almost getting dislocated on the left side, very unstable knee. So bilateral robotic knee replacement was done, and she can walk normally in just 1 month after the operation. All the sticks have gone, and she is confidently walking and doing all her daily activities. Another and last patient, where patient is having severe waddling deformity and gait, and we did again a bilateral robotic replacement, and patient now is walking again very straight. He was a military man and he's back to his normal gait, and he can absolutely do all his activities without any pain. You can see the smile on his face, and that's the beauty of robotic surgery. And this last patient is a farmer by profession, and she was not able to do any activities of ADL. And now see how all the activities she can do without any walking aid. She is able to sit cross-legged, which is very important in our Indian culture. She is able to go on very rough surfaces, uneven surfaces, walks on the farm also. And she can even uneven surface where for a normal person also it's difficult to walk on such difficult terrain. And you can see she is walking ahead of younger women also, and able to do her all normal activities without any problem. She can even squat down. She can do farming work. You can see she is squatting down and doing all the farming work. So the lady who was a burden actually for her family now is a earning member of the family. And so we have given her back not only a good stable knee, but the joy of life and painless stable knee joint. So all the activities she is able to do, and the most difficult action she does is going down the slope, which is very difficult for a normal person also. And you can see without taking walking aid, she is able to go down a steep slope also. So that's beauty, because we have preserved all her ligaments, and the proprioception or the position sense and the stability of the knee is great after robotic knee replacement. So we do a lot of robotic surgeries here. Daily, we are doing about 20 to 25 knee replacements at our center. And definitely, this is a great advancement for our patients in who have knee problems or hip problems, and patient can go back to their normal life. So thank you very much, and sorry for the earlier technical glitch which we had. If there are any questions, I'll be happy to happy to answer that. Okay, I suppose there are no questions right now. I think you can, if there are questions or any queries, you can communicate with us on our email or on our WhatsApp or whatever. And Blue Health can coordinate our opinion. If you have some cases who require our help, we are just a message away from you. And we will be also coming to Ethiopia and either Jan or Feb. And definitely, Ms. Priti is coordinating all the things. So I'll request Blue Health to circulate our contact details. So if anybody wants to share any patients' case reports, then we are happy to help them. Thank you very much.
All right, thank you so much, Dr. Narendra, for the great presentation. We would like to also thank the Lukmania Hospital and Dr. Narendra for this.